Yes, thank you, Hannah. Good evening, everyone, and welcome to this Thursday teaching webinar organized jointly by Orthopedic Research UK and the Orthopedic Academy as part of our FRCS teaching webinar series. So we welcome this evening our guest, Sandesh Lakkol, who is a spinal consultant working at University Hospitals of Derby and Burton. Mr. Lakkol deals with all aspects of spinal surgery, from degenerative conditions to trauma to metastatic spinal conditions, but he's especially interested in pediatric spinal treatment and scoliosis. So we're very pleased that he's accepted our invitation to present tonight, and I'm certain we will all learn a lot from him. My name is Firas Arnaout. I'll be the host and I'll be moderating the session along with my colleagues from the OR UK team, Hannah, Lydia, and Ruth. So the session will include, as you can see, a presentation by Mr. Lakkol. He was going to focus on 3 hot topics for the FRCS exam. He's going to go through the key concepts in these topics. Following that, we will have 3 MCQs as well. We will present to you in a poll, and answers will be completely anonymous. So please encourage you all to try. And they will be based on mainly on what's on the lectures, but there will be some new concepts as well. And Mr. Lakkol will go through the answers with us. Following, so all this will be recorded. Following that, there will be unrecorded session where we have some viva questions, very interesting, related to the spine. And we encourage you all to try to take part. Obviously, exam is coming up soon, and we will give priority to those going for the exam. So please, if you are interested in taking part in the viva component of this teaching session, please express your interest by writing on the chat box or raising a hand symbol, and we will allocate it on first come, first served basis. For those of you who obviously we encourage you to ask questions, and we will endeavor to answer all your questions within the session. If you miss any part, don't worry, it's been recorded and we will post it on our YouTube channel later on within a few days. At the end of this session, we will we'll send you communication email asking you for your feedback, and if you would like a CPD certificate, which we can provide to you. So that's all from me. And without further ado, I will leave you with Mr. Lakkol.
Thanks, Firas. Thanks, Firas, for introduction. Many thanks for invite. So I work in University Hospital, Derby and Burton. So basically, I thought rather than going to a single topic, we can cover quite a few sort of hot topics which commonly come in viva for FRCS. So basically, I'm not going to sort of dwell into the nitty-gritties of each topic, but I'll give you some form of food for thought, some form of armory, so that you can sort of survive those kind of stations if you get in the exam. So these are the common topics in trauma and emergency: Cauda Equina, fractures, cord injuries, infections, metastasis. They're box standard. They will come. One of them, either in adult path, basic science, or in any of those trauma in stations. There are some elective cases. Elective cases are slightly rare: myelopathy, stenosis, listhesis, or scoliosis. Achondroplasia and NF are quite common in clinicals, so knowing them will help. So I'm going to start by giving a scenario. So think about this case. First case is a 58-year-old male, attended celebrating a friend's birthday, fell asleep in a dining chair, fell, banged his head. He's got a severe pain and weakness in his both hands and unsteady gait. No significant past medical history, no significant medications. So this kind of a scenario will be thrown at you. So what are you thinking? So you have to look at the age, you have to look at kind of injury, banged his head, sort of extension type of injury. And then look at what symptoms he has. Look at pain, weakness in the hands, unsteady gait. Unsteady gait hints that there's some element of cord injury, acute cord injury. So basically, you're dealing with a person who has an injury to the cervical spine with possibility of some element of spinal cord injury. So that's what you're looking at. So basically, we're going to talk about or know more about spinal cord injury, how you can approach a patient with a neck or suspected neck and spinal cord injury in any age or any format. Okay. So basically, how can you, how do you examine them? History, examination, Asia score, what resuscitation. In resuscitation is important is you have to keep the map more than 85 millimeter mercury to keep the perfusion of the spine. How can you prevent further injury, log rolling, etc. How can you medically optimize this patient? How can you transfer? Does this patient needs a transfer? Does the patient requires involvement of spinal center? And does this patient require surgery? If at all, it needs surgery. So these are the kind of, you have to start thinking about all these things when some kind of a case is thrown at you, so that how you're going to manage this patient. So what is spinal cord injury? Spinal cord injury is an insult to the spinal cord, resulting in loss of complete or incomplete function of one of the functions of the spinal cord, either it's motor, sensory, autonomic, or reflexive. It's always nice to have some form of definition in your hand, so that it can start as an opening sentence if somebody starts a conversation. So there are 1,000 cases per UK. There are 45,000 people living annually with spinal cord injury, commonly in male, in young people. With the advancement in treatment, their life expectancy has increased, and why it is important, because it costs a lot per case, more than 1.12 million, and per annually it does significantly increase. Common cause is road traffic accident, domestic violence, industrial injuries, sports injuries, violence assaults comes for 5%. Commonest area is cervical spine. Always think of other area of spine involvement. Don't just think about cervical spine only. So around 3 to 25% of the cases, most of the injuries happen because of improper immobilization and during the transport. So this is quite important. So there are two types of injury happens in spinal cord: the primary injury and the secondary injury. The primary injury happens at the time of injury or road traffic accident or assault. That's irreversible. There's no way we can reverse that. But the secondary injury, which is important, that depends on systemic factors, extracellular factors, and intracellular factors. They are the ones which we as clinicians have control, and we can optimize for the patient so that they don't develop it. For example, shock, hypoxia, hypothermia. You can stick them on oxygen, give them fluids, blood, whatever is required, stop the hemorrhage, and prevent hyperthermia. So intracellular factors, we're aware that lipid peroxidation, free radicals, cytokines cause cell apoptosis and cause secondary damage to the spinal cord. So we as surgeons, the medical and surgical treatment is optimizing the secondary injury. So I'll come to that in the next slide in the treatment. So know some definition: what is complete, what is incomplete spinal cord injury. Complete means there is no motor or sensory function below the level of the neurological level, what we call, like say it's T6 or T10 or T12. Incomplete is there is some residual neurological function still exists. Know the anatomical involvement, what is quadriplegia, tetraplegia. Quadriplegia is because the patient has a spinal cord injury at the cervical spine involving both bilateral hands, bilateral leg, viscera. Tetraplegia is paraplegia is either thoracic or lumbar sacral involvement with the involvement of trunk or legs and viscera depending on the level of injury. No, the incomplete spinal cord injuries, they do come quite often in exam. Central cord syndrome is one of the commonest one. Know them well. I can't go each one of them because it's I have to cover the rest of the topics as well. Cross section is quite key. So if there is a spinal cord station, knowing the spinal cord cross section, drawing it loudly, it is key. So predominantly there are two descending tracts and the ascending tract. The descending tracts of lateral corticospinal tract and ventral corticospinal tract, the ascending tract of dorsal column for fine touch and proprioception, lateral corticospinal tract for pain and temperature, ventral for light touch. The important one you need to remember, or the one you need to draw, is when you are asked either central cord syndrome or anterior cord syndrome or posterior cord syndrome. Common is central cord CTLS is the way the nerve roots are organized. The fibers of the nerve roots are organized in the spinal cord. Cervical being the central, thoracic, lumbar, and sacral being the farthest. That's why you will have upper limb involvement more than the lower limb in central cord syndrome. So basically, I'm not going to say how you're going to do the survey. You know, when you get this patient, you're going to say, I'm going to do a head-to-toe examination of this patient from a secondary survey, making sure this patient is inline immobilized. So you will do an ASA chart on admission, and also don't be swayed by spinal cord injury and distract from your assessment of other things like shock, what is the pulse like, and look for distracting injuries as well. And how can you start planning for the image? What kind of imaging do you require for patients with spinal cord injury? You definitely want CT scan of the neck, AP and lateral. Definitely will require an MRI scan, either of local or a whole span MRI scan, depending on how much or what is the extent of injury, and how you can optimize the medical management, whether the surgical management is required, whether the MDT or any referral to spinal center is required in spinal cord injury patients. So ASIA chart, know them very well. There's a newer one, International Standard for Neurological Classification of Spinal Cord Injury, ICNCSC, and it's mainly looking at how we can classify or grade the motor and sensory examination, but you can just stick to the ASIA chart. Know about neurogenic shock and spinal shock. Be aware how you can differentiate. Neurogenic shock is basically loss of sympathetic tone with hypertension and bradycardia. Spinal shock, always in the ASIA chart document bulbar cavernous reflex. The best way of doing it, all the spinal cord injury patients, you will have catheterized them. You log roll, pull the catheter, and do a PR whether they have any contraction of the anal tone. So that's the more civilized way of doing bulbar cavernous reflex, apart from whatever is described in the textbooks. So ASIA chart, ASIA impairment scale is based on what is the motor function and what is the sensory function. A is bad, E is good, where normal motor and sensory function. B is no motor function, with incomplete sensory. So C and D is the one where you have to differentiate. C is where the key group muscle below the level have power less than 3. D is where the key muscle group have power of more than 3. So that's the best way of you can describe ASIA impairment scale. Okay. So how will you work up a patient if you get a spinal cord injury? You need a CT, as I said, MR, blood test. You need to brace them. Maybe basically same patient. If you think about this patient will require Aspen collar of some form of immobilization. You ask them for a bed rest, log roll, catheter, analgesia, IV fluids, oxygen, blood. Make sure that the blood pressure is optimal for a cord perfusion. MAP should be more than 85 millimeters of mercury. Contrary to what we think for spinal cord injury, but for them, better to have either normothermia or hypothermia. There are a lot of papers suggesting that hypothermia is good for spinal cord injury patients. Think of pressure area care, document it from the beginning. Think of DVT prophylaxis. And always the question comes whether to give steroid or not. No steroid, unless you get the patient within 8 hours of injury, which is very clear. Or if you're supposed, if you want to give a steroid, if you're not the person who is going to do the surgery, speak to the person who does the surgery to see whether he needs to, this person needs to have steroid or not. So the current sort of approach is spinal cord injury patients, we don't generally give steroids because the risks of complications are high, mainly with the high dose steroid. So the one line answer is no, unless within 8 hours, because there is a Mike Felling's paper sort of statement from AO suggesting that you can give a high dose treatment if the patient comes within 8 hours. In reality, that option, getting patient within 8 hours to a spinal center is less likely. So the safest answer is say the complications are high, therefore I would not give any steroid, or I'll speak to the spinal centers and seek their advice. So surgical treatment, why do you need them? All incomplete neurological injuries, you need to stop the secondary injury. Basically, the surgery is to prevent the secondary spinal cord injury. In complete spinal cord injuries, it is basically to make them stable so that they can get rehabilitation. With patients of Asia C or D, they are more likely to get better. Who are very incomplete neurological injuries, they are likely to get better if you act early and if you offer them surgical management. So the goal of surgery is to minimize the secondary injury. This is what you're going to say. Decompress the area of the interest, stabilize, and allow early rehab. Timing. When do you want to do the surgery? As soon as you get the patient, you're going to take the call to either to a regional spinal center and tell them and transfer them. If you are the person who is dealing with this patient, earlier the better, in a safest environment. For example, if you get the patient evening or night, the best time is to do the patient surgery is in the morning. So the window period from the time of spinal cord injury to get the surgical treatment is anything between 24 to 36 hours. So is there evidence? This is quite a landmark trial in 2012 statistics trial. So it's a multi-center international prospective cohort study. Basically, they looked at the primary outcome of Asia impairment scale grade in patients who are treated with decompression surgery within 24 hours. And they looked at patients who had surgery within 24 hours and more than 24 hours. So patients who had decompression surgery within 24 hours after spinal cord injury had better outcome, and they improved their Asia impairment scale grade by 2 at 6 months follow-up. So you can certainly mention this, saying that why earlier surgery is better. And also the recent Lancet paper, which kind of accumulated not just the statistics paper, but other papers as well, which is a 4 independent prospective multicenter data of 1,500 patients. They looked at patients who went early surgical decompression versus late decompression, and they found that patient who had surgical decompression within 24 hours of acute surgical injury had a better outcome in comparison to the patients who had surgery after 36 hours. So the crucial window is, you can say, within 24 to 36 hours since from the onset of spinal cord injury. So that's kind of nutshell of spinal cord injury. Okay. So the next kind of common sort of scenario is 46-year-old female, bilateral sciatica, numbness from to feet, which is from 2 days, which is progressive. The history of lifting a heavy basket of shoes 4 days ago, and then felt a pain down the left leg. Now has bilateral leg pain, which is progressive, numbness, and increasingly becoming immobile. So if you look at this history, it's a young person, female, started unilaterally down the left leg 4 days ago, progressed over the 2 days to bilateral. There is a numbness and there is weakness, immobility. So you're looking at somebody who had a disc prolapse becoming more and more worse and who is developing into Cauda Equina syndrome. So that's how you can think and put your thought process into it if this kind of a scenario comes into it. So the Cauda Equina syndrome is an emergency condition where lumbosacral nerve roots are compressed within the lumbosacral canal, presenting with combination of symptoms of altered sensory and motor function of the lower limbs, perianal, perineal, bowel bladder function, confirmed by an MRI scan. This is, I like definitions because it kind of puts everything in one nutshell, and you can always, it gives you kind of an overview of what this condition is. So after that, that scenario, you'll be kind of shown this kind of a picture. So, what can you see and how can you approach it? You can say is a sagittal and axial view, T2 images of L45 disc prolapse, L45, of the lumbar spine, showing L45 central disc prolapse with complete effacement, or almost complete effacement of the CSF. My concern is of Cauda Equina syndrome. So, and then, so why does Cauda Equina syndrome happen? What are the normal disc prolapse? Some people have huge disc prolapse, but they never develop Cauda Equina syndrome. But in Cauda Equina syndrome, there are two things. One is the mechanical compression happens, which decreases the nutrient delivery to the nerve root, decreased blood flow and CSF diffusion. The secondary is something like a compartment syndrome, which is a time-dependent factors, which will progress if you don't act quickly and if you don't pick up symptoms quickly. So where there is a venous condition, intraneural edema, and from a hypoperfusion injury with further decrease in the arterial perfusion and nerve ischemia, and therefore, and then this, you've got autonomic dysfunction of the bowel and bladder. So it's a progressive sort of cascade which happens once the primary injury, which is with the mechanical compression, happens. So therefore, the Cauda Equina presentation is always a spectrum. A patient and this patient always goes from one stage of Cauda Equina syndrome to another stage. I'll come to that in the next slide. So the early stages, and I'm not going to say, what is the incidence, prevalence, and all those things. So what are the early stages where you need to be very careful while you take a history and while you examine them, is for looking for bilateral numbness or weakness in the leg. Carefully ask and assess for perianal or perineal sensory disturbance if they have a numb bum or genitals, and the bladder dysfunction. Can they feel the full bladder? Can they get the desire to pass urine? And when they pass urine, are they aware of passing urine? So these are the quite key early red flag symptoms. NICE gives a host of symptoms of bilateral red flag symptoms, You can look it up in nice website, but I'm sure you all are aware. In history and examination, from the you always look for whether they had unilateral sciatica, did they develop bilateral sciatica, did they develop any motor sensory changes, did they start having sudden back pain which got suddenly worsened, is there any perianal anesthesia, hypoesthesia, any sexual dysfunction, and then bladder dysfunction or defecatory dysfunction. If they develop all those things, then you're kind of in the final stage of Cauda Equina. So that is the history part, apart from the general other history you're going to take in Cauda Equina. In the examination, along with motor, sensory, and reflexes, the perianal sensation, anal tone, an anal wing sign is something which is useful. The question is, let me ask you, is anal tone is very sensitive in picking up Cauda Equina? There's a lot of studies have shown that anal tone is not that accurate test in detecting early Cauda Equina or Cauda Equina incomplete syndrome patients. But in fact, what is more important is carefully assessing perineal or perianal sensation and documenting it clearly in comparison to the rest of the leg or rest of the body. Important one, every patient with Cauda Equina, if you get a patient with Cauda Equina, you must do pre and post void scan. Normal is around 50 to 100 ml. Every trust or every region networks, spinal networks have a certain criteria. What is normal? What is this cutoff for scan? One of the study done in Nottingham by Mike Revitt et al. Of the group, they looked at the patients who came with suspected Cauda Equina and how many of them had their pre and post void residual scan. And their kind of take-home message is if the post-void residual is less than 200, then it's a 97% negative predictive value for Cauda Equina. So 97% chance that it could not be. So in their group, only 3% patient chance that they could have Cauda Equina syndrome. So in a sense, you can say the cutoff is 200 ml. So if the patient has less than 200 ml, you can say the chances are less likely, but you can carefully observe. You will admit the patient, you will do a serial post-void residual scan. If they get into more than 200 ml, then it's a worry. That means they're progressing. But if it is more than 200 ml, that the chances of Cauda Equina syndrome is, I think in their studies, around 47% or so, around that. You can look it up. So which is something important because it's a UK study, and this is one of the important clinical signs you must do in Cauda Equina syndrome. So I'm going to spend quite a lot of time in this slide because this is what you need to know, because this is kind of a natural evolution of Cauda Equina. When you suspect Cauda Equina, what happens? What happens in early Cauda Equina? Incomplete, in retention, and incomplete. So when you suspect Cauda Equina in people who either had long-standing back pain or long-standing leg pain, who start developing bilateral sciatica with motor or sensory loss, this is called clinical Cauda Equina suspicion, with no bowel, bladder, genital, perianal symptoms. And when you confirm it, it's called radiologically confirmed suspected Cauda Equina syndrome. The early stage of Cauda Equina is they still have normal bladder, normal bowel or sexual function, but they do have sensory loss around the perianal area, and then they have some change in micturition. Another key stage which to pick up when you assess this patient is the patient in incomplete Cauda Equina syndrome. Means this patient has control of the bladder, but has altered sensation in the bladder function or urethral sensation, bladder sensation or urethral sensation, or if there is any perineal changes or sexual or sensory functional changes. So this is quite a subtle stage of Cauda Equina syndrome, where if you catch them early, and the surgical intervention will have some impact on their outcome of urinary function. So if you leave if this patient with a large disc, who say, oh, his bladder is a bit funny, urethral sensation is not there, oh, he's got control, so we can just leave him alone. If you don't pick these patients, they will go into retention. So that's the next stage, CSR, where they will develop a painless bladder retention and overflow. The fourth stage is Cauda Equina complete, where they have insensate bladder, overflow incontinence, no perineal sensation, no anal tone, where you pass PR, it's like completely lax in a young person. So the BARS has made it easy for you. You can mention BARS classification of Cauda Equina, where you suspected with the absence of sphincter dysfunction, incomplete with dysuria, urgency, or altered urinary sensation, with retention, CSR, painless retention of fecal urinary overflow incontinence. The reason I go back to the slide is because the early, if the treatment or surgical treatment or early surgical treatment of suspected Cauda Equina syndrome or early Cauda Equina syndrome or incomplete Cauda Equina syndrome, they are certainly better in comparison for patients with CSR or complete Cauda Equina. So, so as long as you can tell that in a coherent way in your exam, I think it's a good brownie points, I would say. So, and if you're going for exam, you must know the two key things is when to do MRI scan and who should do MRI scan. The MRI need to be done at the earliest opportunity as soon as possible. If your place hasn't got MRI, I mean, my advice is if your place hasn't, if the scenario is that your place hasn't got MRI facility, the best is to, depending on the clinical scenario, speak to the spinal services, get their advice, whether the advice could be that do as a first thing in the morning so that they can wait for a slot for the surgery, or some centers do advise for transfer overnight if there is a convincing evidence that the patient is in Cauda Equina and deteriorating in a rapid way. So the BARS guidance is that the person who is examining first time or referring must do MRI scan and then transfer to the local spinal services. But some centers, some DGHs may not have the facility to do MRI scan, so you have to keep that in mind. But for exam purposes, you can almost recite whatever is there in the BARS guidelines. So with regards to surgery, I will come back to it. Sorry, we can talk about, we can finish it here itself. So when you need to do the surgery for Cauda Equina syndrome, so the best is earliest as soon as possible and as safely as possible, taking into account of symptoms and their duration and their progression. We'll always have to, so there is a caveat to it. We need to consider the potential for increased morbidity if you're operating in the night. So you're not going to operate, somebody comes at 10 o'clock with complete retention, which has been already established for more than 10, 12 hours. There's nothing you can gain by operating in the middle of the night. But if a person came in with intact bladder function to ED, while waiting in ED, develops or goes into retention, even if it is around, say, 8, 9, 10 o'clock, then these are the patients, probably a subset of patients who have deteriorated in a short span, where urgent or emergent surgery may make a difference to these patients. So you need to take into multiple accounts. At the same time, you have to say, I will also, I mean, if the question comes back to you saying that you are the spinal surgeon in spinal center, what would you do? You need to, I will still look at the patient progression and the availability of theater and staff and resources, and then I'll take an executive decision whether to do it in the night or in the morning, whichever is safest. Okay. So the best is within 24 hours of onset of symptoms, or within 48 hours. Within 48 is considered as acceptable, because most often all these patients, they don't present straight away. So it's very difficult to catch them within 24 hours from onset of symptoms. Certainly we can do it within 24 hours of presentation to ED, but within 24 hours of onset of symptoms is quite difficult. But at least we need to try to get these patients treated within 48 hours. But the exam answer is as soon as possible, as soon and safe as possible. So what kind of surgery you're going to offer, or what you're going to say, or what will you write in the consent? So all these patients will have a large disc. So microdiscectomy, even though it is described as a option of treatment, there's a high chance of dural tear or complication. Therefore, we will offer them central decompression and discectomy. And again, you need to go through the consent and what you're going to say, and all those things, in case if you go to that level of the topic in your discussion. So there's a recent paper from Ireland, comparing the timing of surgery and Cauda Equina syndrome classification based on BARS guideline. They had around 136 patients, 69 in retention, 22 in incomplete, and 45 in suspected group. Surprisingly, in their study, they didn't find a significant difference in improvement in the bladder function if they had surgery within 24 hours or after 24 hours, mainly in Cauda Equina syndrome retention or incomplete. So they conclude saying that early surgical decompression within 24 hours from the onset of symptoms does not appear to significantly improve the bowel or bladder dysfunction. But this is a retrospective study, and it's very difficult to without a randomized trial, you can't clearly say that such a strong statement of early surgical decompression will not have a significant impact. But contrary to that, we can mention another paper which is slightly old, but again they looked at Cauda Equina incomplete patients, and they reported that the normal bladder function can return in around 90% of the patients, around 88.9% of the patients, if you treat them within 24 hours. That's quite significant. So I would say still, if the patient has Cauda Equina incomplete, then the early surgery will have a better outcome. So there are quite a lot of other studies, but some of them are historical now. You can know, but there may be questions asked, is there evidence for early surgery? You can throw one of these papers into the discussions. Any more questions on this? Sorry, I'm going a bit fast.
No, brilliant, Sandesh. You're not going fast at all, actually. Excellent pace, because it's good, very good, concise slides. So we're all enjoying it. So I think you have one more third topic, but if you like, I can give you maybe a bit of, everyone a little break and ask some questions. Is that all right?
Yeah, it's fine.
Yeah, you might well doing that. So question from Vilas. He asked about Cauda Equina secondary to METs. Are any particular guidelines on management are you aware of?
For the METs?
Yeah, secondary to METs. Cauda Equina secondary to METs.
I mean, my next talk is about that. spinal cord
Good. That's good then.
tumor.
So, Vilas, yeah, I think listen carefully to the next talk. Then the answer might come through.
I mean, I don't know about the. I mean, there is a nice guideline on spinal cord metastasis. That is something which you need to
I think that will
do,
apply
but
to it.
that's mainly for spinal cord compression. But the same kind of rules apply for,
Yeah.
I must say, for Cauda Equina as well. Bear in mind with the commonest area of spinal metastatic compression is thoracic level because of the Batson plexus. So you rarely have Cauda Equina level compression. And another thing is the Cauda Equina level, the tumors tend to have the spinal canal is large and they're nerve roots, so that even with the significant compression, you don't seem to see the extent of sudden deterioration of the neurological function what you would observe in a thoracic level tumors or thoracic level metastatic fracture compression or tumor compression.
Oh, that's interesting. That's interesting.
But it's not. I'm not saying it's not. It is slightly rare, but commonest is what you get is at the thoracic level cord compression in a tumor case.
Yeah,
because of the Batson plexus and on the.
Thank you. We have one more question from Muhammad Nail. He's asked if the post voiding residual is less than 200. What would you do? Would you do an MRI scan, or would you just admit and observe?
It depends, never a single entity will determine a patient's fate.
Yeah,
you go back, examine history, careful things. And every jigsaw puzzle is to make you a proper informed decision. If a patient has more convincing symptoms or signs, I would still get an MRI scan, even if it's less than 200. I wouldn't just because post-void residual is 200, I'm not going to send a patient back home. If I'm clinically, when I examine and when I take on a history, I'm convinced that this patient might have a Cauda Equina, I'm never going to say, go back. Or I will still, if I'm if I think clinically this person is in that clinic, Cauda Equina incomplete type of scenario, I will sort of nag the whole local spinal services or whoever it is to do the MRI scan, or take this patient for an MRI scan. So that number is just so that you need to have some standard number to say which one is normal, which one is abnormal, etc. And some hospitals have very strict rules for what is a cutoff. As a Nottingham, local hospital, they use 200 ml as a cutoff. We in our hospital use 100 ml as a residual, etc. So some hospitals may use even 50 ml, but that is it's purely based on the whole entire examination of the patient.
I think agree with you totally. It's multifactorial, isn't it? It's never one deciding factor. You have to look at the whole picture, and for exam purposes, the number one priority is being safe.
Exactly.
Okay? No, you have to be safe. If you're not safe, you don't pass the question, no matter how much evidence you quote. You got to be safe. And then for the exam, MRI scan. You MRI scan everyone. There's no point in but then obviously you can argue the cases and argue the risks and things like this, and you can put on your support.
You can always, I agree with this. You can always argue. There are a lot of papers who have done whether it is justifiable to transfer patients overnight from DJs to centers, and they found out that only a fraction of patients turned out to be positive. And they compared it with people who came to their own setup and found that who had overnight MRI scan. So they said There's no point in transferring overnight to a specialist center. And you can argue and debate, and you can throw those kind of evidences. But at the end of the day, as Faraz mentioned, you always say, go back. I want to say, make sure that this patient hasn't got Cauda Equina. So I will go back, examine, and I will specifically look for these things. So that as long as you demonstrate that you're not gonna just leave the patient in lurch, and you're gonna make sure that this patient is safe, probably not to have a MRI scan, and you demonstrate that insight, and how you demonstrate that insight is the key. You can't just say, oh, just because you said, oh, less than 200, oh, I'm not going to do MRI scan. Probably that's not the right approach.
Yes, absolutely. I think, yeah, you can, it's a very hot topic, isn't it?
Well, I mean, to be honest, most of the people stay away from Cauda Equina because it's such a controversial.
Yes. Not an easy one to take on.
There's nothing, I've told whatever is there in the BAS guidelines, so at least something for the candidates to talk about and read more about, basically, nothing more. I'm not given everything, I've just given some of it, isn't it? Okay, so shall I go next? Yeah?
Yes, please, if you could.
So the next typical case is a 65-year-old lady come to clinic with more than 12 weeks in history of low back pain, radiating the right leg, progressively worsening, walking distance is limited due to pain, significant amount of painkillers from 1 month, tired, sleeping has become difficult due to pain. So it looks like vague history, but there are buzz things. 60, more than 60, high chance of cancer. Yeah. 12 weeks, kind of a short duration if you consider for a back pain patient. And 1 month, progressively worsening. So there is a short, sudden worsening. And sleep, nighttime pain. So there are 3, 4 quick, big things in the history itself will sort of give you a hint that it could be a tumor or rarely an infection. So that's how you have to align. So if somebody say what's going on in your mind, you say 65-year-old lady, and this is a short history, and I'm a bit concerned that this could be tumor. That's my differential. So how are we going to do a clinical assessment? How are we going to take a history from looking at their pain, origin, past medical history, if they have any constitutional symptoms of cancer, any history related to primaries like breast, thyroid, prostate, lung, etc. And then you do an examination from head to toe, looking from primary and neurological examination and looking for lumps and bumps, etc. And then you go for investigations, what kind of a blood test, imaging, medical management, whether there's MDT involvement, and what kind of a surgical treatment. So these are the whole spectrum of sort of questions and sort of answers you may be encountered during this kind of scenario. So common carcinomas which spread to the bone are from breast, lung, thyroid, renal, and prostate in that order. So the survival is good for thyroid, and then for prostate, breast, reasonably. So if there's kidney and lung, they got poor survival, but these are all historical figures from the paper, I think from 2005. But the up-to-date ones certainly, definitely will be much better than this prognosis. I wouldn't quote this, but at least if you know the order, that'll be good. Bone is the third most common site for metastasis. First is the lung, liver, and bone. So that's why you always get a CT chest of the pelvis to see if there's a visceral involvement. In bone, spine is the most commonest, and then proximal femur and humerus. In spine is the thoracic spine, is the most commonest one. So pathophysiology part of the metastatic spine, they can cause osteolysis or osteoblastic. Osteolysis is caused by tumor-induced activation of osteoclast. It's again mediated by cytokines, interleukin-6, interleukin-11, parathyroid hormone, and TF-beta. They stimulate osteoblasts to release ankle, and then that binds to rank, and then stimulates the osteoclast and osteoclastic activity. Osteoblastic bone metastasis is mainly from endothelin, which stimulates the osteoblast and also it activates the BNT pathway. So lung, thyroid, renal are primarily light. 60% of the breast are blastic. 90% of the prostate is blastic. So after you've gone through this patient, you've taken a history of pain and onset of symptoms, etc., as I mentioned before, and what next, they'll ask. So what next is, you're going to test, you do the blood investigation, basics, FBC, differentials, ESR, CRP to road, if there's an infection, metabolic profile, calcium, myeloma screen, LFTs, etc., which is, you can add other, screening for specific cancers as well, but these are at least the basic ones you must do in every patient you see, even in a suspected metastatic cancer patient. The general image workup, the CT chest abdo-pelvis, and then bone scan to see if there is any extent of bone metastasis apart from spine itself. And in some cases where there are cold spots in myeloma or thyroid tumor, you may have to do a skeletal survey, X-rays as well. Specific, that is a wing scan, just in case if you had this kind of a patient and if they're shown an X-ray, because nowadays you generally sort of jump to sort of CT or MR, rarely you take a AP and lateral of X-ray, but the recommended normal sort of investigation strategy is to have an AP and lateral of that in spine, preferably a whole spine standing, to see if they have any deformity. CT scan is important, at least at the area of involvement, or you can to see if it is a lytic or a blastic tumor, and also to know the bony architecture if you're planning for surgery. Best or the standard treatment, standard protocol now is to get a whole spine MR as a screening for any other areas of metastasis if you are suspecting one. So if you have a patient who have no primary carcinoma, so then biopsy is a key. So if the patient has no neurological deficit, then you will do a biopsy, send a specimen for histology and wait for the histology to come back and then plan treatment. If the patient comes with metastatic sort of a lesion in the spine with no primary, or what you call as CUP, cancer of unknown primary, with cord compression, then we'll do biopsy, at the same time decompression and stabilization, wait for the histology to plan for either radio or chemo, whatever you plan to do. So then how do you derive to the level of who gets to surgery? I mean, patients with primary cancer with metastasis, they're not the fittest of the lot. So who and how you can decide who will require surgery or decompression or stabilization, etc. A couple of tools which you need to know is Tokohashi Score, which is based on general condition of the patient, how many extraspinal bony metastases are there, how many vertebral bodies are involved, is there any visceral metastasis, what kind of a primary tumor, and if there is any neurological compromise. As you can see, rectal, thyroid cancer, breast, they've got a higher score, but if you have a lung, esophagus, pancreas, or a liver cancer, they've got a very low score. So the scoring is collection of all these things you put together. 0 to 8, less than 6 months of mean survival. 9 to 11, more than 6 months. 12 to 15, or more than 12. So often, this was proposed in 1990, revised by the same authors in 2005, and they did their own validation. They said it's around 87% accurate, but again, it's been regularly contested, and one of the studies done by a Nottingham group again showed the usefulness of this is around 66%, and some of the other papers have suggested even lower accuracy in predicting their survival. Yeah. So, but this is definitely, you need to know to say that how can you predict the survival before deciding for surgery. The other one is the norm score, depending on pain, location, type of bone lesion. Is there any spinal alignment? How much collapse is there? Is the or involvement of posterolateral involvement? If the lower the score, better for the patient. Better for the patient. Up to 6 is stable. Up to 12, 7 to 12 is probably unstable. 13 to 18 is definitely unstable. So again, it's just not the score itself you're going to treat. You're going to look at the patient, you're going to look at the other scores, and you're going to involve the MDT. And the norms is another framework which is commonly used for consideration of who gets what kind of a treatment. So you look at the neurological function, you look at the oncological diagnosis, look at the mechanical stability, and look at the systemic illness. For example, if you have the high-grade epidural spinal cord compression, then they require surgery and then radiotherapy. And if somebody has a mechanical instability, then they require surgery. If they have mechanical instability with just a burst compression fracture, then you can consider kyphoplasty or vertebroplasty. So if somebody has a radio-resistant tumor, then they, without compression, they'll go for radio-resistant tumor with compression, they'll go for surgery. Again, we can't forget the fact that we'll always look at the patient systemic illness, what is their overall outlook looks like, whether they're capable of handling this amount of morbidity of the surgery, because these cancer operations are not small, they're big, they bleed, and it takes long time to recover. So you look into all these aspects before deciding surgery. Again, it's never a single person decision. It's always a multidisciplinary team approach and MDT decision. So palliative care, you have to think about palliative care if the person has a life expectancy, depending on the, as we talked about Tokohashi Score, if they're less than 6 months, then palliative care also. In some patients, radiation alone is useful. So the surgery is mainly for neurological decompression, stabilization, and then you plan for postoperative radiation. The cutoff, most of the hospitals, most of the spinal MSSC centers use is more than 6 months, at least survival to decide whether this patient should go for surgery or not. So this is a landmark paper from Roy Patchell in 2005. I think after that, the nice guidelines of MSSC came into play, which is a randomized multi-institutional trial looking into surgery followed by radiotherapy and radiotherapy alone. In their group, patients who had surgery and radiotherapy had better ability to walk after treatment at their final follow-up in comparison to people who just had radiotherapy alone. So this kind of changed the scenario from treating all these patients with metastatic spinal cord compression from steroid and radiotherapy to decompression surgery and radiotherapy. So even in this paper, the patients who had surgery needed less steroid and opioid analgesics, which again is beneficial to the patients. So that is it, guys, from my side. Any questions?
That's wonderful, Mr. Lakkol. That's really amazing. I think each of these 3 topics is a whole lecture on its own, and you managed to put the 3 in them in one. That's really wonderful.
I mean, I thought just, just a little bit of food for thoughts, isn't it? I haven't given anything.
Yeah, it's perfect. From my point of view, having been teaching for FRCS for a long time, I think for the exams, you don't need to know anything above and beyond what's in this presentation. So I think wonderful one. And I encourage you all guys to come back and see it, see the replay when it becomes available in a few days. Yes, we have some questions. Obviously, as you know, the Cauda Equina always a hot topic, but question from Sherwan asking, can Cauda Equina syndrome present with the unilateral sciatica?
It can.
Yeah.
One line answer is it can.
Yeah. That's good. That's good enough.
Yeah.
Absolutely.
Because at the end of the day, if somebody has unilateral symptoms, has perianal numbness and retention, not always patients should have bilateral symptoms.
Yeah, exactly. It's a whole multiple factors again. If someone just coming with unilateral sciatica and everything else is fine, then that's not the Cauda Equina. But unilateral does not exclude Cauda Equina. Yeah.
No. Just because patient has one unilateral symptom, I'm not saying unilateral. Patient coming with unilateral symptoms with completely blacked out CSF. So it's. Yeah.
So one more question we have here from Fazal. He's asking: Is there radiological correlation with the clinical classification of Cauda Equina? How would the radiological features correlate with the clinical presentation? I think in terms of acute or pending Cauda Equina, I think.
I mean, there is,
And how is the progression time scale as well?
I mean, I think
it's unpredictable, isn't it?
It's a good question. I mean, I think what he's trying to ask is if depending on the degree of compression, can you predict? I mean, it's not the Cauda Equina compression is not that it's going to progress. The Cauda Equina compression has happened. I go back to the pathophysiology slide where the mechanical compression happens and the secondary injury of intraneural pressure develops. So that is where it's happening. So it's actually this clinical scenario changes. The radiological picture remains as same. If he is trying to ask, I'm not aware of any paper which correlated the degree of stenosis of Cauda Equina and their association with Cauda Equina in retention, or I don't think it has any significance in decision making. My decision making is my patient. You look at the patient, examine, and take a history, and then you confirm it with the MRI scan. And MRI scan is to confirm, not to grade. Yeah, in my view.
I think generally in orthopedics, isn't it, the correlation between the radiological findings and the clinical findings not always standard, or they don't follow each other all the time, isn't it? So I think.
No, I think the question was I think he was trying to ask whether you can grade the, suspected incomplete retention based on MR, if I understood that correctly.
Yeah. No, I think that's difficult, isn't it? That's difficult.
I don't think you can.
Yeah. So we have one more question about your first talk, about in relation to the Asia classification, type C and D, and how the question is how from Dylan. He's asking how do you choose the key muscles to examine?
How do you? There is an ISCSN chart.
Yeah,
you can Google it and it will show you exactly how you need to examine the key groups. There's a specific way. It will give you a demonstration exactly from each myotome, each dermatome, how to examine. So I think it's in the. That's a talk in itself actually. So, but that's what I would suggest you to go back and read ISCSN. I don't know the full form. But that's the normal chart which most of the spinal cord injury units are using nowadays.
Thank you. Thank you. Now, one more question from Jamie. If a patient with metastatic spinal cord compression attains and they are off legs, what's your standard approach? Do you go for MDT or do you decompress urgently before final MDT decision is made?
Um,
And I think
if
that's
the-
probably if you are working a spinal unit now, isn't it?
yeah, I mean, in
not
our
on
spinal unit, it depends on the primary, and it depends on if the patient is off legs. Is that what you?
Yes, patient off legs. Yeah.
Yeah. If again, you go back to what is the primary? What is a known primary? Is it a aggressive tumor? Is you get a you do the hits, everything as and always said. You do the bloods, you do the CT chest abdominis. You see, you get a whole spine MRI scan. If somebody has, if that person has a life expectancy of less than 2 months, making that person go through a big I mean, there's some patients we have said, person is off legs, but he has, life expectancy is weeks. So for that person to have a big operation, you discuss with the patient, whether do you want to have a surgery with the hope that there is a chance of improvement. It's this the cord compression patients will not have a significant improvement in neurological function. In metastatic cord compression patients, your operation is to stop the progression. Somebody is already off legs. Unless the person has a big, long prognosis from a cancer perspective, you're not going to offer surgery. Again, it's a conversation you need to have with the patient. You're not going to operate on the middle of the night, definitely not. And again, in those patients, you still give them steroid.
Yeah.
In cancer patients, you do give them steroid. Sorry.
Yeah.
Not in spinal cord injury patients.
Okay, thank you. I think we got to remember again, we are here and focused on the FRCS level kind of questions and exam scenarios. And I think if you are, they'll assume you are a DGH consultant when they ask you the questions in the exam. So for a DGH consultant, when you get this case, you are discussing with the spinal surgeons on call, with the spinal center, and you are discussing, there's always an oncologist on call. So you can have a mini MDT, even if it's no matter how urgent, you can always have a mini MDT between a general orthopedic and the spinal and the oncologist. So yeah.
I mean, if I need, I will speak to the oncologist.
Yeah.
But again, it's just going off like because of the cancer, or I'm going to jump and operate. It's not the thing. You just always go back, look into all the aspects, and again involve the patient. Sometimes even involve family as well.
Okay. There was a question when to do an MRI if you're suspecting METs, but there are no clinical signs apart from pain.
If you suspect METs, get the scan then.
Yeah, yeah, absolutely. There's no point waiting at all. And any role for steroids? I think you answered that. Any Naji asked any role for steroids in Cauda Equina syndrome?
Not Cauda Equina.
But you've already answered that. So that's.
But if it's Cauda Equina secondary to tumor, then certainly yes, there is a role.
Brilliant.
Not for cord compression, injury, trauma.
Thank you. Thank you. Well, Mr. Lakkol, thank you very much indeed for this wonderful, very comprehensive lecture. You covered 3 very hot topics, as the title says. You'd actually delivered what you promised, definitely. It's a wonderful, very focused lecture, and I've certainly learned a lot, and I'm sure everyone who's watching has also learned a lot from this. Reviewing this again, and I'll use a lot of the papers and things to update my book on it. So with your permission, I'll use that. So thank you and for answering all the questions from the audience. Now we'll move on to the MCQ section. So Mr. Lakkol has kindly prepared 3 MCQs. Please, may I ask people attending now, may I ask everyone to please answer? The answers are anonymous, so you could say, you could give it your best guess. You won't be judged. No one will know what you answered. And just to check your understanding of the topics, and also just to consolidate what you've learned tonight. And we will go, Mr. Lakkol will go through the answers shortly. So we'll give you about 3-4 minutes maximum to answer these. And while you're waiting, I will, on the chat box, I will share some information about some of our upcoming courses. We have an FRCS mock exam. There are some observer places available, and we have other FRCS courses. I will share some information on the chat box for you guys later on. So
go through them.
Yes, please. If you could kindly go through the answers.
So the first one is, please select the most appropriate statement in relation to Kodakone Syndrome. So I gave 4 or 5 options. So the correct answer is actually the 5th one is in Kodakone incomplete. Patient may have reduced bladder or urethral sensation or saddle sensory disturbance, but retain bladder control. Yeah. So the first question, if you look at it, it looks like it is true, but there are significant, a lot of papers showing that, patient can have normal tone even in Cauda Equina, or patient can have an abnormal tone and have a normal scan. So it's not that reliable. Again, another thing is objective loss of perianal and genital sensation is confirmatory. Actually, in comparison to anal tone, the objective loss of perianal and genital sensation is more superior in diagnosing Cauda Equina, but again, it's not confirmatory. Yeah. The third one is patient with incomplete Cauda Equina syndrome has completely normal examination. No, they don't. Patient with reduced anal tone and loss of perianal sensation always have Cauda Equina. No, both of them, they can have both and then still not have Cauda Equina. So there are rare cases. So that is the correct one. And then the second is, which of the following statements is true regarding management of spinal metastatic cord compression? The first one is prognostic criteria using revised Tokohashi score is very useful in predicting. Is not very useful. I've said it, it's around 60%. Since score alone determines the need for surgery. No, it doesn't. That's good. Everybody said no. Surgery for metastatic compression is based on life expectancy, nature and origin of tumor and spinal instability only. Not only, no? Because whenever there is only, or it's confirmatory, so never is that is the correct answer. So patient treated with direct decompression surgery plus postoperative radiotherapy, superior outcome in comparison to patients treated with radiotherapy alone. That's the correct answer. I think they've got 63% got it. That's correct. Perioperative embolization should be considered in all renal and myeloma patients, not in myeloma, thyroid patients. Not myeloma, renal and thyroid patients, not myeloma patients. Okay. Which of the following statements regarding the management of spinal cord injury is not true? For the first is spinal cord injury patients need to manage with optimal hypothermia or normothermia, which is true. Spinal cord patients presenting within 12 hours, high dose prednisolone should be considered to prevent secondary injury. That's wrong. You don't consider that. Unstable complete spinal cord injury require surgery. Yes. Decompression prior to 24 hours is associated with improved neurological outcome as at least 2 grade AS improvement at 6 months follow-up. Actually, that is more stronger positive answer in compared to unstable complete spinal cord injury. Yeah, urosepsis is the commonest cause of commonest cause of death amongst the spinal cord patient is again true. So that's the true statement. which is not true is the second one.
The answer is quite reflective of the reality, and these questions in the exams are tough, and we would not expect 100% of people to answer that. I think an answer rate of between 60 to 75 or 80 is the normal expected range.
I think they're a bit difficult as well. I mean,
Yeah.
made it a bit difficult, so that's quite good actually.
Yeah, yeah. Anyway, it's not the exam here, it's just here to make people think and see what else they need to prepare to get ready for the exam. So that's wonderful. Thank you very much. Thank you very much, Sandesh. I think